Thank you very much. Good afternoon, everybody. I'm sure we've had a wonderful time thus far. Professor Hans has given us a lot of what we need to know, of what needs to really ginger us, to convince us, to convict us that we need to pay attention to the nutrition of these preterm babies, especially in the first few weeks of life. And these weeks are those weeks spent with us in the newborn unit. We have to do something. And I'm sure we've also seen that breast is best as he has presented to us. So everything to make breast available to these babies in the first 4 weeks of life is so crucial. So it's from that perspective that I'll be taking tonight. The topic this afternoon. We're looking at the challenges, the feeding challenges, particularly breastfeeding challenges, and solutions in preterm infants. Looking at our perspectives in Nigeria as a low and middle income country. Well, we know the burden of preterm infants, preterm delivery is quite high. Globally, about 15 million preterm babies are born every year, which constitutes about 11% of total annual deliveries. And we know prematurity is the single most important cause of neonatal deaths. It accounts for about 1 million neonatal deaths every year. It's the second leading cause of under 5 mortality globally after pneumonia, and it is the same in Nigeria. So prematurity is not something that is so far-fetched. It is something, it's a big problem we deal with on a daily basis. 60% of preterm births occur in Africa and Southeast Asia, with 28% occurring in sub-Saharan Africa alone. So really, this problem is with us. Majority of the problem is around us in sub-Saharan Africa, and we need to do something. We may not be able to do everything, but that which we can do, we have to look at these problems and try to address them. And that's why I appreciate FrieslandCampina Institute for this opportunity to rub minds and look at these issues together. So what are the problems of these preterm babies? Of course, preterm babies have a lot of immediate and long-term challenges, which you find in every single organ system of their body. However, the nutrition-related problems are at the center stage. Like Professor Hans showed us, nutrition is one major thing that we can control. It's an environmental factor that can impact on long-term health. So, and it is possible to affect it or to impact on it. So that's why we have to pay attention to nutrition. Over the years, nutrition has now emerged or is still emerging as a potential factor to improve the overall outcomes of individuals, to improve their growth, to improve their national productivity, because it's the quality of individuals that we bring up that would ultimately affect our national productivity. So that's why nutrition is not a misplaced topic, especially in these preterm babies, bearing in mind the fact that they have a lot of challenges or problems relating to nutrition. So I'll just be talking about the immediate problems relative to nutrition in these preterm babies. We know they have poorly developed reflexes, sucking, swallowing, the coordination. Sometimes even when they have suck, even when they can swallow, if they don't coordinate this well, then they cannot feed and swallow appropriately. And this does not occur until sometimes between 32 and 34 weeks gestation. So babies born before this period have a great deal of challenges with feeding orally or feeding enterally. They have reduced stomach capacity. The size of their stomach is small, is a function of their body weight. They also have reduced digestive capacity. So all these are things we need to factor into consideration when we are thinking about their feeding. And as such, you have to look at how much you give per unit time. We have to look at the quality or the type of food we put into their digestive system that they can handle, which is where the emphasis on mom's own milk is not misplaced at all. And Professor Hans did he talked a lot about that. They also have increased permeability across their mucosal membranes. So this implies that they can readily have mucosal damage and which can result in necrotizing enterocolitis. Also, we can have a lot of macromolecules getting absorbed, getting translocated via their gut into the blood, thereby stimulating uh, immunologic problems for later life. So that's why we really need to pay attention to what we put into their stomach, into their gut, so that they do not develop this mucosal damage. And of course, Professor Hans also talked about this, the critical illness they have during that neonatal period causes increased nutrient needs, and at the same time they may not even be able to handle the so much nutrient needs they have if we try to give so much of that. And being preterm, not having enough stores at the time they are born, they have increased and special nutrient needs for their catch-up growth and development. So on the long term, if these issues are not adequately addressed, they are at increased risk of neurodevelopmental problems, including retinopathy or prematurity. All of these, I'm sure, we picked from Professor Hans's presentation, so we're not really going to dwell on them. Of course, increased risk of cardiometabolic diseases, and these are related to their early life growth restriction as well as a suboptimal neonatal nutrition. So we do not want to create the environment for these children to have long-term cardiometabolic diseases. So that's why we cannot afford to let them be malnourished in the newborn period, especially those first 4 weeks that they typically spend with us in the newborn unit. The importance of nutrition in preterm babies cannot be overemphasized. We heard a lot of what happens the details from the presentation of Professor Hans. I just pick a few things. They have greater energy. Evidence has shown that greater energy as well as enteral feeding during the first 2 weeks of life will predict a more robust brain growth and accelerated white matter maturation. He showed us that. And proper nutrition brings about long-lasting improvements in neurodevelopmental outcomes. So these are things that should serve as watchwords for us in the newborn period, in the newborn unit where we look after these babies. We want, especially those first 2 weeks, we want them to have greater energy and enteral feeding. We saw from Professor Hans's presentation how deficient energy would result, or even protein intake would result in suboptimal neurologic performance, intelligence of quotient figures later in life. So we have to, right from the day the baby arrives in the newborn unit, we are thinking of this baby. We don't want to miss the opportunity of giving nutrients in these first 2 weeks. And of course, the evidence is still emerging on these epigenetic effects of early nutrition on the programming for later development of cardiovascular diseases, overweight, obesity, diabetes, and the other chronic conditions. So nutrition in these preterm babies is something that from the moment you resuscitate them and bring them into your unit, you start planning for. And also, evidence has shown that early enteral feeds in preterm babies reduce late onset hospital acquired infections, is associated with reduction in necrotizing rates of necrotizing enterocolitis, and is associated with reduction in all-cause mortality, and of course reduces overall length of hospital stay. And by this, it will reduce cost of hospitalization, which is a major factor that we in this part of the world have to think about, especially when you remember that we pay out of pocket for healthcare, and majority of our patients are impoverished already. In fact, that is probably part of the reasons why their babies ended up coming preterm and required attention. So it's a multifactorial situation for us in this part of the world. So what do we need to meet the nutritional needs of this preterm infants? Of course, Professor Hans talked about guidelines. He talked about protocols. It's crucial. So preterm feeding guidelines that have been developed generally aim to start early. We don't want to miss the first 2 weeks of getting good nutrition into them. We want to advance this rate of feeding, enteral feeding safely, and we want to use the best nutrient possible. And like he told us repeatedly, it's human breast milk. And number one is mom's own milk before any other consideration, but human breast milk generally. If necessary, we fortify for optimal nutrient intake. And then we want to do measures or take measures that would improve feed tolerance, reduce the risk of necrotizing enterocolitis and late onset sepsis. And that's where the issue of probiotics come in. He also mentioned about probiotics. We want to reduce length of hospital stay so that they don't keep picking infection, the families do not get more impoverished, so that on the long run, we want to improve their survival, but not just survival. We want to reduce morbidity, and we want their survival to be intact survival, such that their quality of life would be worth it at the end of the day. So what are those, just a summary really, based on available evidence. So what are those evidence-based feeding practices that are common in, of course, feeding practices vary from place to place, but some basic principles are there. So evidence-based feeding practices in preterms in high-income countries. Of course, most of this evidence were derived from research in high-income countries. So what are these the evidence-based feeding practices? Of course, use of total parenteral nutrition prior to establishment of full enteral feeds. Babies that are born very preterm, babies that are born before 32 weeks, certainly cannot take all of their enteral feeds from day one. So during that initial period, because we don't want to miss the 2 weeks, the early weeks of nutrient intake. So during that initial period, we add total parenteral nutrition to augment their enteral feeds till we gradually get to full enteral feeds as quickly as possible. We also want to prevent catabolism and negative nitrogen balance. So for this reason, they give amino acid infusion from the very beginning. Give at a rate of 3 to 4 grams per kilogram body weight per day. Gone were the days of starting with one and then slowly progressing. We do not want to do that at all. They also give lipids, parenteral lipids from day one for optimal brain growth. That is the key. That's the most essential part of the body that we require for everything we do in life. Then, of course, the necessary micronutrient supplements. They need water, they need fat-soluble vitamins, water-soluble vitamins, calcium, phosphorus, and trace elements, as well as electrolytes. So these are the key things that these babies are provided, preterm babies are provided for in the immediate newborn period. So how do we, in this part of the world, key into this? So what are those things that are done to achieve some of these feeding guidelines that we talked about? Number one, to promote gut maturity and feed tolerance, because we've said breast is best and breast can only be given enterally. So what is done to very preterm and very low birth weight babies is to start trophic feeds early and then gradually advance. But rapid advancement has been shown to be safe, so that we reach full enteral feeds by the end of the first week of life. We want to maximize brain growth in those first 2 weeks. And of course, human breast milk is preferred. So mom's own milk is number one, donor breast milk is next, if in the hierarchy of things. But if none of these are available, then any milk is preferred to no milk. And that's where the preterm formula comes in. But we saw from what we heard earlier that feeding them with human milk is certainly better than any preterm or standard term formula. And then some other measures that have been used to promote gut health and feed tolerance in these babies is to start early buccal colostrum until the baby is able to feed by mouth. Even when we are still feeding by tube, you still want to stimulate the oropharyngeal passages with the colostrum, just drops of colostrum in the mother. And then the use of probiotics and symbiotics to modify the growth microbiome, though the best species, well, are yet to be determined, but evidence has shown that this helps. So on the basis of all the available evidence from developed countries, from high-income countries, because we don't have so much research to inform feeding practices in low and middle-income countries, and WHO recognized this. For that reason, they try to modify the evidence from, or let's say adapt evidence from high income countries to take care of the cost constraints in this part of the world, to take care of logistic issues, and adapt for us a practicable guideline for feeding these small infants. So the guidelines address for those babies that are above 1.5 kilo. It addresses those babies that are less than, that are between 1 and 1.5 kg. The presentation of today is not for me to go into that, but it's just for us to know that WHO has attempted to modify the recommendations from high-income countries such that they are practicable in our setting. But it doesn't take away from the fact that we need research in this part of the world to inform our feeding practices. So having said that, now to the real topic of today. What are those challenges with preterm feeding in our country, in other low-income countries? Based on what Professor Hans has presented, we have now known what is necessary. But what are the problems we have that is making it difficult or impossible for us to achieve these things? Number one, he talked about national feeding guidelines. We rarely have national feeding guidelines in many low and middle income countries. This is mostly because we do not have research to inform such guidelines. And of course, in recent times, Nigeria is in the process of developing one, and hopefully that will be launched soon and we'll be able to get that to use. And of course, in the face of that, not having national guideline or uniform guideline, practices vary across units in Nigeria, as well as other low and middle income countries. Maybe except for few countries like Kenya, they have always had their written protocols, but of course not based on evidence derived from their country. What we have largely, we have the essential newborn care course and WHO guidelines for feeding those babies that are above 1.5 kilo, which if people use would at least achieve something for these babies. But you realize that many centers still do not comply or follow these guidelines for feeding. Apart from not having national guidelines, many units or most units don't even have their own unit protocols or guidelines for feeding. So that's why even within the unit, practices may vary from person to person. So these are some of the problems we have that we need to look into and address. Of course, available evidence for these feeding guidelines are largely from high-income countries. We rarely have local data. So this is the way to think. This is the way to go. We need to generate local data on feeding practices and see what is best for our situation. And of course, we're talking about these protocols. Even when available in some centers, they are not uniformly complied with. So you have a lot of variation in feeding practices. So it's really difficult to even tell the effect or the impact of our various feeding practices on the outcome of our babies. Then other challenges. We've heard that breast is best, and we would desire that every baby that is admitted into the newborn unit, every preterm baby admitted into the newborn unit, should really get mom's own milk. But what do we have? A very high rate of out of hospital deliveries. Less than 35 or about 35% of our deliveries in this country are supervised by skilled birth attendants. So the rest are born out of hospitals. So it's after they are born that they now get sent to secondary and tertiary centers. So this kind of poor system of referral causes separation of baby from mother. You find a baby delivered by cesarean section in some hospital, even some private hospital, and then the baby is referred alone to the tertiary center. We do not have breast milk banks. We do not have means of getting mom's own milk. So even when you want to feed from day one, the mother is not there to provide her breast milk for her baby. Or the mother has delivered outside, she's sick, she's not able to come, and the baby has been sent to us, and we cannot give what we know to be best for this baby. So you are torn between the devil and the deep blue sea. Do I want to keep fasting or starving this baby until mom's own milk becomes available? Or do I want to do formula because mom's own milk is not available? So these are some of the challenges that I'm sure many tertiary centers face from day to day. And of course, we have other impediments to early commencement of enteral enteral feeds, because even within the same hospital, the mother is sick, she's in ICU, the mother is admitted somewhere, there's no support for expression of breast milk. So the mother is there away from her baby, she's sick, the baby is there in the newborn unit, and we cannot get what we desire for the baby. So we need to work on that. Uh, Other problems include the issue of not having breast milk banks. If we had breast milk banks, that would have provided a suitable alternative in situations where the mothers are not available. Even when the mother is available to maybe express breast milk, hardly do we have enough facilities for safe storage. When you have the refrigerator, there is no power supply, or the refrigerator is not even available. So the mom is only there to express as at when needed. So in situations where there's no support for the mother to sit around, it now becomes a challenge getting fresh breast milk to give to her baby. So these are some of the problems in our part of the country. And of course, when the milk is not available, you are unable to achieve your desired rate of advancement. So once you don't achieve your desired rate of advancement of breast milk, we do not get to that full enteral feeds as at when due or as at when desired. If the mother has to travel from some 20, 30, 40 kilometers each day to come and provide breast milk for her baby, some days they are not even there. So you want to increase the feeds as appropriate, you cannot, because the breast milk is not available. So that now brings about the need to introduce breast milk substitute to these babies. The cost of breast milk substitute, will agree with me, is quite prohibitive in this part of the world. So we really have challenges trying to feed these babies as we know is best for them. But of course, it's left to all of us to think of how we would surmount these problems. In our country today, majority of our healthcare spending is direct out-of-pocket spending, and everybody knows what the economy is doing. So families are not even able to provide the minimum that they should provide. So these are some of the challenges to preterm feeding in our country. Other challenges would include various myths and misconceptions about breast milk or breast milk flow and its contents. Till today, some cultures still discard colostrum. They believe it's dirty. They think it's not valuable for the baby. Meanwhile, that's one of the most valuable components of the mom's own milk. Some cultures still discard that, and the baby is losing out of the benefits. And some people just believe that no matter what, a baby must have pre-lactal feeds. So even before trying, they already give the babies glucose water, and these are not these are deleterious. Some of us healthcare workers, we just have it somewhere in our brain that, oh, if we do not give prelactal feeds or if we do not give other things, these babies will develop hypoglycemia. This fear of hypoglycemia may actually be unfounded. And for this reason, when you give prelactal feeds, we delay the availability of mom's own milk. And you hear in some quarters, even healthcare workers, they have this common phrase, especially in the first few days, first 2, 3 days of life. They tell you, oh, the mother is not lactating. They believe the mother does not lactate in the first few days. These are some of the challenges militating against our getting breast milk, which is best, to our preterm babies in the first few days of life. And these have long-term implications, as we've heard. For some others, they just believe, oh, breast milk substitute is superior to breast milk for preterm infants. And that notion would make mothers prefer to buy some expensive breast milk substitute rather than settle down to provide breast milk for their preterm babies. But I'm sure we've seen today, or we've heard today, that even if the child is not achieving that much physical growth with breast milk, the brain growth and development is superior. And I believe that is paramount on our mind, much more than physical growth and probably obesity later for the babies. The other challenge with breast milk is if the baby doesn't seem to be growing or is not getting enough nutrients and we do not want to increase volume excessively, sometimes we desire to add breast milk fortifiers. It's not readily available in our country, and when available, it is out of reach. The cost is prohibitive, so that's another challenge. And of course, but for exercises like what FrieslandCampina Institute and some others are doing now, there is rarely do we get enough information to our healthcare workers who care for preterm infants, or maybe we do not spare enough time to try and avail ourselves available information that is best on the breast milk for this baby, so on feeding practices for these babies. So this is an area that also is a big challenge and we need to do something about it. We said in the first few days, when we are unable to give enough breast milk or a full enteral feeds to these very preterm babies, we need to give them total parenteral nutrition to balance whatever we are giving. This should not be given through peripheral lines. The central lines that we need to deliver this are not available. Even when available, they are not affordable, and safety is also of concern in terms of infection handling and otherwise. So that is one of the challenges. The TPN preparations that are largely available in this country are not really specific for neonates. Occasionally, sometimes we get the appropriate amino acid that is suitable. It's not like there is a particular brand that is very specific to or best for neonates, but some are certainly not for neonates. And most of the time, these are the available amino acid preparations that we have. Lipids are not available for neonates. And of course, we have a lot of infections in our unit. So when you are doing central lines, when you are doing parenteral lipids, infection is something we have to pay attention to. So these are the areas of challenge, the gray areas with respect to delivering total parenteral nutrition in this part of the world. Of course, our inadequate lab support, because once you are doing total parenteral nutrition, we need to monitor for the metabolic consequences, which is not very readily available to us. When available, they are quite expensive. So this makes widespread use of total parenteral nutrition not very common in our country. So having seen some of these problems, what's the way forward? One thing is certain: breast is best, and that is what is mostly available to us in this part of the world. So how do we ensure, what do we do to surmount these challenges to ensure that we get enough breast milk to these babies, such that in the first 2 weeks of life we would get to full enteral feeds and these babies will get appropriate nutrients? So the only reasonable and widely available affordable option for us in this situation is early introduction and rapid advancement of breast milk to facilitate tolerance of milk feeds, as well as achievement of the full enteral feeds within this 2-week window. So what do we do to make breast milk available to these babies? Well, what is not expensive and what is immediately practicable is something to do with our mindset, changing our practices, passing the information round, is the need to encourage in utero transfer of preterm and very preterm babies to avoid separation of babies from mothers. If a baby comes to a health facility and that facility is not equipped to care for preterm babies, if the mother is in labor, please refer the mother. So the mother will go and deliver in the hospital where both baby and mother can be cared for from the time of delivery. We also need to have formally trained lactation consultants to help us improve breast milk expression, breast milk provision by our mothers who have just delivered. And this will go a long way in improving breastfeeding issues, in solving breastfeeding challenges among these mothers, especially new mothers. Then we have to promote and improve some of the methods, some of the traditional practices. I know in some parts of this country, they use surrogate mothers to breastfeed. In the absence of a mother, in the absence of breast milk banking, I think this is a viable option. However, in terms of infection, in terms of acceptability and all that, we have to look into how to improve the methods so that we do not give babies milk from infected mothers. So, screening for HIV, checking for hepatitis, teaching these mothers, counseling, and all those things that will make these mothers willing and available to help breastfeed babies whose mothers are not available to breastfeed is another way to consider. And of course, continued training of healthcare staff caring for preterm babies. We need to keep hearing it all the time. The value of breast milk, the value of early enteral feeds for these preterm babies, the value of preventing infection. So we keep talking about these things and we keep finding solutions to them. But of course, one big step would be to establish breast milk bank. Establishing breast milk bank would go a long way in providing milk for those babies whose moms are unable to get milk, especially in the first few weeks of life. Again, we have said most of these recommendations for feeding are derived from adapted from research in high income countries. So we really need to conduct research into nutrition interventions for preterm babies in our setting, and it's urgent. In fact, I wish we could bring Professor Hans to come and help us in that regard in this in our country, because he has a whole lot of experience in that area, so that we determine what is feasible at every level, what is efficacious, what is affordable and safe for immediate and long-term health outcomes in our babies. For instance, when we consider something like use of fortifiers to promote growth, you wonder, is it the physical growth we need? Is that big necessarily the best for our babies or future outcomes? If they grow so fast, so rapidly, physically now, are we sure that would not impact on their long-term health in terms of cardiovascular issues, obesity, and all that? So we need to know, is this best for us? Is this best for brain growth? But until we do the research, we really cannot tell. But in any case, it's not even available or affordable for now. So these are some of the things we need to take away from here. And the use of probiotics to facilitate healthy gut flora, prevent infection, and also that nutrition gut brain axis. There is some synergy in that area. So we really need to conduct studies or research in the area of probiotics in this part to see what it will do for us. Is it going to be helpful for our babies? Is it going to be affordable? Is it going to be efficacious? Is it going to be safe? And then which species would be best for us in this part? We cannot just assume. We really need to conduct research in that area. I think at this juncture, I would like to say a big thank you to everybody for listening.